Welcome to another session of the International Society of Fluorescent Guided Surgery, our monthly webinar that is sponsored also by Diagnostic Green. Dr. Fernando Dip, our society president, is going to take over in a few. Today we are privileged to introduce to you Dr. Martin Newman as our guest speaker. For those who don't know Martin, I know Martin now for 22 years. He's been the department chair of plastic surgery at the Cleveland Clinic since 2005. He was a resident with us, a fellow. Martin has held different offices. He's the former president of the Miami Society of Plastic Surgeons. He's currently the president-elect for Broward County Society of Plastic Surgeons and a board member of the Florida Society of Plastic Surgeons. His interests are in not only plastic reconstructive surgery, but also for us in Florida, he's our melanoma guy. As a background, he received his medical degree from Vanderbilt University School of Medicine in Nashville. He then went ahead and did plastic surgery at New York Presbyterian Hospital in Columbia, Cornell University in New York, plastic surgery residency, and finally came to Cleveland Clinic to suffer with Brian Boyd and Harry Moon, his aesthetic and cosmetic surgery, both great plastic surgeons and dear friend of ours. He's currently involved in fluorescent image guided surgery. He's authored 13 book chapters, over 50 peer-reviewed manuscripts, and he's also a clinical professor of Florida International University, board reviewer, editorial board member, et cetera, et cetera, et cetera. So without any other further delay, I'm going to let Dr. Newman take the floor and talk to us today about sentinel lymph node evaluation in melanoma. Fernando, you take it from here, yeah?
Thank you.
And I go into hiding.
Dr. Rosenthal, thank you very, very much for that wonderful introduction. Can you all see my screen?
Yes.
Great. Alrighty. Well, we're going to be talking about melanoma and sentinel lymph nodes and the ability to identify those sentinel lymph nodes with ICG. Just looking at quick history, some of us were in medical school in the 70s and 80s, and that's when this first started to come about. Lymphoscintigraphy was done with colloid gold to identify the lymphatic drainage pattern in the melanomas. Morton developed a technique for intraoperative mapping and then to selectively remove those lymph nodes in the direct drainage pathway of the melanoma. It was a great advancement from the old 5-centimeter margins that were taken back in the day. This sentinel node was considered to be the first site of metastatic disease. Fast forwarding to the 1990s at the John Wayne Cancer Center, they had a multidisciplinary team that got together and employed the visualization of this drainage with breast cancer patients. They used radiolabel colloids, and they combined it with intraoperative dye detection, both in the melanoma, of course, and the breast cancer patient. Identification of this sentinel lymph node was then done using a gamma probe, and a pre-op lymphoscintigraphy was added subsequently. That's the general concept. It's kind of a visual. And towards the turn of the century, Turner validated this work at the John Wayne Cancer Center. And he found that if the sentinel lymph node tumor was tumor-free, that the probability of undetected involvement on other lymph nodes was less than 1 in 1,000. And this is really what validated the work for use in not only melanoma, but in breast cancer. And it's when sentinel lymph node became kind of the standard, and everybody moved from full lymphadenectomy with its high morbidity and mortality to the sentinel lymph nodes. So what is our current technique for a sentinel lymph node biopsy? Well, I know that the attendees are certainly well familiar, but we are using ICG in all of the different sentinel lymph node applications. The standard technique, of course, uses these tools. We have the gamma probe. the nuclear medicine study, the lymphoscintigraphy. This is sometimes today combined with CT for a more accurate, precise locating purpose. This is what the traditional nuclear medicine studies look like. Whether or not they do get the lymphoscintigraphy preoperatively, they do get the injection with the technetium-99, and some of the breast surgeons I know will inject that directly in the operating room. Usually, however, we inject the technetium-99 the morning of or the night before. The blue dye is injected on the table. We use a gamma probe, and we take 10-second counts in vivo, and then we remove the lymph node in question. We certainly take a 10-second count of the bed, expecting to see a drop less than 10%. And then we take a 10-second count of the node ex vivo and document these numbers. The lymph node is often, but not always, blue, using our standard technique. I remember as a resident, I was looking at the lymph nodes and the surgeon would say, yeah, I think that's it. You know, we put the gamma probe on it, and maybe it was blue and maybe it wasn't. It wasn't always very clear to me. Nuclear medicine, of course, has drawbacks. It's costly, it's very traumatic for the patient, it's time consuming. There are many schedule concerns associated with something like this. There are radiation concerns with using nuclear medicine. And as an administrator, I can tell you that it is a voracious consumer of hospital resources, where we're always looking to save a dollar here and save a dollar there. Sending a patient to the nuclear medicine suite takes time, and it takes a significant amount of hospital resources. Blue dyes indeed have their own set of drawbacks. There is a hypersensitivity reaction of 2%, and I've spoken to people who've unfortunately been in that situation where they've injected methylene blue and seen the patients crash. These anaphylactic reactions have indeed occurred. Methylhemoglobin can completely throw off the pulse ox. If you've ever used methylene blue in the operating room, you know that it's toxic to the tissue and it stains everything it touches. And like everything else we like to use, it's invariably on national back order and becomes a problem sometimes when you need it. So what about identification with the sentinel lymph node with the ICG? Well, our hypothesis when we set out was that it is an acceptable alternative to the blue dyes. And when the lymph node basin is known, ICG can actually obviate the need for nuclear medicine, the injection of the radioisotope, lymphoscintigraphy, and of course the cost and the expense of the gamma probe. So that's how we kind of set out. And to kind of look at this a little more closely, we had to ask one important first question. And that was, what is the concordance if you're using ICG and technetium-99 in the identification of sentinel lymph nodes in our particular population, in this case, the melanoma patient? And to answer this very important question, we did a literature review, and I performed a retrospective meta-analysis of all the papers we can get our hands on that actually used ICG or technetium-99 in the identification of the sentinel lymph node in melanoma patients. The nature of this particular study was a systematic review of the literature. Only original study groups were included. False identification rates, or false negative rates, were pooled according to radiocolloid, blue dye, ICG, or a combination thereof. And the outcomes were our measures of test performance. We actually found quite a few studies. We went back to the 1990s, so the original work, and we followed it all the way through 2016. We found a total of 456 patients in 14 studies that examined one or the other. And when we did the meta-analysis, we found that they really were pretty much equal. There was certainly no statistical difference. The blue dye and the technetium-99, plus or minus the tech-99, would identify an average of 1.4 nodes with the range listed. And if you used the near-infrared camera and injected ICG, the results were almost identical.
Martin, if I may stop you here for a second, I want to ask all the participants, we are now close to 50 people, to ask questions. Do it please to the chat room if you don't feel like speaking up, so that Dr. Deep can interrupt Dr. Newman and make this more of a dynamic and, you know, I would say entertaining session.
Excellent.
So,
I'd like it.
keep going.
I'd like it to be a conversation. Absolutely. Please feel free to interrupt me.
Dr. Martin, I
Yes.
have a question. I have a question for you. So this is, I believe these numbers are really very important because we are defining here, because we have one method that is technetium-99 that, you know, the identification rate is, we know that it's very high. On the other hand, we have this technology. So in your practice, because this is what the literature says, but in your practice, do you have the same results? These results are the same in the different areas in the melanomas that you can find in the back or in the limbs? Or
Absolutely.
Yeah.
In fact, I've abandoned the use of blue dye totally. I do employ technetium-99 when there is a questionable lymph node basin. So for example, if you have a melanoma on the back, we know it can go to the bilateral axilla, we know it can go to the bilateral groins, we don't really know where it's going to go. So I think that a lymphoscintigram is very helpful in these cases. But for a known lymph node basin, and I'm going to show a video in a minute of a known lymph node basin, you can totally obviate the need for technetium-99. Just more on the study. And what we found was that the systematic review of the literature from those studies that I mentioned showed no significant difference in the sentinel lymph node identification rates between the ICG and the technetium-99 in our patient population, in the melanoma patient. With respect to the blue dyes, we noticed that in all cases, ICG performed equally to or better than the blue dyes. And more to your question, the reason I've abandoned the blue dye and utilizing ICG now is because there are many cases when I'm in the operating room where the ICG, shows me clearly, without question, the sentinel lymph node. For example, in a matted lymph node basin, or in a situation where, there's a secondary lymph node there that is not being picked up by the technetium-99, and certainly not by the blue dye at that point. So there are times where I honestly believe it's much, much better.
And what is your advice for someone that it's going to start with this technology? So they should jump on the technology directly, or they should continue doing or using technetium and start comparing both technologies? What is your advice?
Well, my advice is to do both, to run them parallel for a while until the surgeon gets a comfort level and, works out the learning curve, which in this case is probably one case. And you'll see by the videos, it is so inherent, it is so clear cut that there's really no question where the melanoma is. But I wouldn't recommend anybody just go into things and just blindly start. We're all experienced surgeons. We know that we have to take slow steps. We have to be careful. So certainly continue to get the lymphoscintigram and inject the technetium-99. Continue, start working with the ICG. I'm going to show some tips later on the injection technique. I think that like anything else, the more you do, the more you know. You want to know what abnormal looks like. So you should do a bunch of normals. I wouldn't start with the worst possible case. I would say to myself, I'm going to give myself 10 cases of very routine stuff, get very comfortable with what normal looks like. And then, of course, when you start getting those difficult cases, pull out all the stops.
Martin, I have a question, Raul here. Do you need an IRB for this if you practice in the United States? Do we need...
I'm not familiar with the need for an IRB. I can't tell you things are on or off label, but this is something that I've been doing for the last, 15 years or so. I mean, it's just the way I practice.
Sounds good.
So I mentioned technique. Let's take a look at this. I think that, one of the most important things is the quantity. Some of us that are gut surgeons may inject 1 or 2 cc's peripherally through the peripheral IV. As a plastic surgeon evaluating skin flaps, I'll inject up to 3 cc's at a 2.5 milligrams per cc. But in this particular technique, we're going to inject into the dermis, right where the melanoma is, and we are going to inject much, much less. And I'm going to repeat that. We're going to inject much, much less. If you start by injecting 1 cc, into the tumor, you're going to have a complete whiteout or green out of your screen. So what I do is I take my ICG mixed with 2.5 milligrams per cc, I put it in a 1 cc TB syringe, and I inject 0.1 or 0.2 of that cc just to get things started. And then, of course, we would take out our ICG camera, our near-infrared camera, and we follow it as it begins to course through the skin. Now, for the head and neck doctors, where the skin is extremely thin, it is so crystal clear. It's like following a roadmap. You can actually see it course through the skin. Some places on the trunk, especially the back skin, it's a little bit thicker. You may not catch it all. But let me show you a video just to kind of illustrate what we're talking about. So this is a melanoma on a man's arm that is in between his elbow and his axilla. This is going to go nowhere but his axilla, 100% of the time. So in cases like this, we don't necessarily need a lymphoscintigram. This was one of my early cases, and I have done a lymphoscintigram on this patient. I have had the gamma probe out, and you can see clearly where I think the lymph node is going to be based on that. But this is a perfect example of a known lymph node basin. This is not going to the groins, it's not going to the other side, and it's not going to the lymph nodes here because it drains proximally. Let me show this video again and illustrate the small, minuscule quantity of 2.5 milligrams per cc that I'm injecting. That's a TB syringe, so 1 cc syringe. I like to withdraw the plunger before I take it out of the patient so I don't get too much spillage. And I'm illustrating here that it's just 0.1 or 0.2 cc's that I've injected. I then take out my ICG camera and I begin to trace it. And as you can see here clearly is where we injected it. These are the lymphatics. First they ramify, then they coalesce, somewhat like the brachial plexus. See that? And if you watch this closely, you can actually see the dye going through the lymphatic and then diving into the axilla. So you know exactly where to go. A minute or two later, it has ramified, it has coalesced, it's tracking up and diving into the axilla right here. On the next slide, what I'm going to do is open the axilla, and then I'm going to do a blunt, I'm going to repeat that, a blunt dissection. We don't want to cut any lymphatics, because if you cut the lymphatics, you're going to get spillage all over the place, and you're just going to get white everywhere. But as you can clearly see, if you do a blunt dissection, you get this glow that looks like a lighthouse on a foggy night that will direct you towards the lymph node in question. In my practice, I like to put a 2-0 silk around the lymph node and kind of manipulate it. That's how I dissect it without hurting it. And you can clearly see your lymph node there. Here it is what it looks like on digital image. It's a nice, healthy looking lymph node. Once it's removed, I take another video of it just to show how bright and how wonderful it looks. There is no question, it is so inherent. I'm not the resident I was 20 years ago going, well, is that blue or I can't tell? I mean, it's so clear cut.
Martin, I have a
Yes.
question. So in order to perform this kind of procedure, you need to turn the lights off the OR, or you can work with the lights on?
I think that's equipment dependent. Some of the manufacturers have created cameras that are immune to ambient light. Some of the older cameras are still, grayscale where you got to turn the lights off in the room. Many of them now have different modes where you can look at green and you can look at overlays and things like that. So I think it's equipment dependent. And if people are just getting into this, chances are they're getting the new equipment, which should not necessarily mean you have to turn the lights down.
Martin, I have a question from the audience. Stephanie Knowlton, and please identify where are you calling in from? Stephanie is asking us, or is asking you, if you find that ICG proceeds past the sentinel lymph node to the second tier lymph nodes, and if that is a problem in your view.
It's an excellent question, and no, I have never seen that. I have not let it go more than an hour. because, you know, by an hour after injection, I'm usually out of the operating room in these cases. But I don't know what the long term is. Like if you inject it the night before, I don't know if it'll ever leak out. ICG is a very large molecule. And one of the reasons we found it so helpful in plastic surgery is because it stays in the interstitium. It doesn't leak through the little pores in the vessels. That allows it to flush in and flush out. And the lymphatics, I believe the large ICG molecule is trapped within that sentinel lymph node. Again, I can't say what it would look like 12, 24, 36 hours later, but I've never seen it go beyond that.
And Michael Redman is asking if you use technetium-99 in the head and neck for midline lesions when you're worried about contralateral spread. He's calling us from La Crosse, Wichita, or Wisconsin. Fernando, please take over the chat room, yeah? I don't know if you see it, that they're asking questions.
So that's a great question. Here at the Cleveland Clinic, Florida, we defer the head and neck melanomas to the ENT, the head and neck surgeons, because it sometimes involves a full neck dissection, and they're much better at that than I am. Yes, we use it. And yes, you can determine which side it goes to and what lymph node basin it does. In fact, in the videos that I've been showing, which, you know, you can kind of guess where, you know, that's kind of tracking. You can see it, but in the head and neck where the skin is thinner, it's a lot clearer than this picture. Here's where the injection site, it's gone into the lymphatics, they've coalesced, and they're diving here into the axilla. But if you ever see a head and neck video, it's much more impressive. And we'll localize it.
Stephanie is telling us that she's in Boston and works for a consulting company in healthcare, and she's interested about new technology and new techniques. So Martin, how about the dual modality to use white light and near-infrared light at the same time? Why don't you do that instead of working in the dark?
Well, you're looking at grayscale images that are not really taken in the dark. This is some of the early work that I did. I think the videos are very impressive, and I've always kept them because they are very clear and illustrate what can be done. So it's not as dark as it appears on the image. But yeah, absolutely. The newer cameras are not affected by ambient light, and you can just use them. In fact, even newer technology down the line that I've had a privilege of seeing, at its early stages, of course, it involves kind of a virtual reality where people put on goggles, or they use headsets, or they use Google lenses or something like that. So technology is advancing very rapidly. The point here is that the dye can be illuminated, and it can distinguish the sentinel lymph node from the adjacent tissue. And it is an excellent, it's, in my opinion, I haven't used methylene blue or blue dye in the longest time. You know, I mean, it's just so clear cut. How one watches it really is technology dependent.
Yeah. Martin, we have another question here from Silvina Berna. She's asking if there is any problem of using this technology in obese patients.
No, as a matter of fact, I prefer this technology in many cases. As I've said, the obese patient is actually a better use of this technology because obese patients are a very difficult dissection if you've ever had to take out an axillary node from an obese patient. The guidance that the ICG provides, again, something like this, where it glows like a lighthouse on a foggy night, can help you negotiate the copious adiposity that we sometimes encounter, and it will direct you directly to the sentinel lymph node.
Martin, I have a personal question. How important is it for you when you work on this delicate area, head and neck and axilla, to see nerves? Would that be beneficial to you?
It would, and there are different applications to this technology in this area. So for example, if we're going to do some lymphatic work, not just a sentinel lymph node, but a lymph node transfer or a complete lymphadenectomy, by injecting ICG distally and watching it come up, the axilla, the arm into the axilla, you can identify those lymphatics that drain this area, as opposed to injecting another dye in the breast or in another portion and watch those come through, so you can selectively pick your lymphatics. And that's kind of chapter 2. As far as the nerves go, you can also illuminate nerves as they do with prostate surgery. In my experience, I'm a blunt dissector. I've been pretty lucky. I haven't knocked out any nerves yet. But I think that if you did a full lymphadenectomy, it could probably be helpful. Everybody there? Just make
yeah.
Sure. Okay.
You want to continue?
Yes. So if this is as good as it looks, and I've been saying, why even use the technetium blue? Or if technetium blue is good, why change? That's the question that a lot of people have. Dr. Rosenthal is the master of laparoscopic surgery, but I'm sure he remembers the day where he would tell his attendings or his seniors about this, and they'd say, well, listen, I've been taking out gallbladders, for the last 20 years. It works just fine for me. Why change? Well, I would say that the ICG has advantages. First of all, as I illustrated, in known lymph node basins, it totally obviates the need for nuclear medicine. And when you do that, you obviate the need and eliminate radiation concerns. If you've ever seen a patient go for the lymphoscintigram the morning of surgery, you know it's extremely painful for them. Yeah, they have to wake up at the hour of like 4 in the morning. They have to get here. Nuclear medicine comes in, they put them on a hard, cold table. They inject them, they leave them there for a number of hours while they do their nuclear medicine. There's a risk involved in that. You cannot do that first case in the morning because you have to wait for nuclear medicine to finish their job. The cost savings, and I reference this little website at the bottom. It can cost up to about $1,600 to do a lymphoscintigram. Of course, there's additional costs and equipment. And again, I mentioned a voracious consumer of hospital resources, not only in dollars, but in time and scheduling concerns. And the imaging that you've seen, I would humbly argue, is really unparalleled. You just cannot compare the two.
So Martin, we have a technology now that is new, that we can see the lymph vessels, that we can see the nodes at same level as the technetium. So in your opinion, what is the rate, what is the percentage of surgeons that are using the technology? This is my first question. And my second is, what is the limitation of the adoption of this technology now?
Well, I'd say the limitation, I'll answer the second question first, is that we don't really use this, certainly not in my practice, for lymph node basins that are not clearly known as a solitary tool. So as I mentioned, if it's on the back or it's on the abdomen and we're really not sure where it's going, because it could go anywhere, we go ahead and we get the technetium 99 to back it up. But for a known lymph node basin, it's unparalleled. As far as I'm sorry, the first question was how many people are doing it? I don't think a lot of people are doing it. It's catching on slowly. I mean, laparoscopic surgery took 10 years to catch on. It's gonna be some time. And I think that literature will certainly help. The literature is growing. Same thing on the head and neck. You don't really have many known lymph node basins up there. It could go anywhere. It could go to the parotid. It could go to the level 1, 2, 3, 4, 5. It can go anywhere. So, on those cases, those are the limitations. And as far as future directions go, we just need to spread the word. And, we're all surgeons. We're all conservative. We've all learned. We've all done our M&Ms, and we know that bad things can happen. So we tread lightly, and it just takes time for something like this to grow.
Perfect. We have another question here from Marcus Malek from the Children's Hospital of Pittsburgh. You mentioned 0.1 or 0.2 cc injections. He's asking, do you only inject in one spot adjacent to the lesions or injecting in 4 quadrants around the lesions? And if so, 1.1 or 0.2 centimeters per quadrant?
So I use one site, and I do it at the site of the melanoma, and I limit it to 0.1 or 0.2 cc's total. I know that when people look at sentinel lymph node, this application, sentinel lymph node for breast, they do, I believe, do the 4 quadrants. And I can't tell you exactly the quantity they use, but I'm sure the literature is replete with that because there's a significant amount of this literature on the breast, as there is in gynecology and the other applications that I mentioned earlier. And as the literature grows, you know, and especially with societies like you and Dr. Rosenthal are running, where you're putting out literature that is going to recommend by a panel of experts certain doses and certain indications, I think that'll only add to the resources that the average working surgeon can turn to.
Thank you.
You're welcome. So in conclusion, I would say that the support for employing ICG for sentinel lymph node detection in melanoma patients, as we say, continues to grow and one day may become routine. Like nipple-sparing mastectomy, like laparoscopic surgery, like any of the things, any of the changes we've seen over the years, the shift from standard protocols to new protocols will take time. It's just the nature of what we do. We want to move slowly, methodically, and safely, do no harm. And as time unfolds ahead of us and additional studies are become available in the literature, I would argue that the use of ICG as a solitary tool, as you can do in the case that I illustrated, where you have a known lymph node basin, will continue to evolve and eventually replace these radioactive isotopes in blue dye.
Well, thank you. We have another question here from Jacqueline Wade. So aside from blunt dissection, what do you recommend when you cannot see an ICG thread in thicker tissues?
Well, if you are using the ICG camera and you need to cut through some of the adiposity or the soft tissue, I think it's safe to go ahead and do so because you can visualize the lymphatics. And if you proceed slowly, they will announce themselves visually, and you'll be able to slow down or employ blunt dissection in those areas. For my particular dissections, I enjoy using the Adson-Beckman retractors ×2. I place them opposed to each other at 90 degrees, and I'm not opposed to making a larger incision if I need to get deep. This is just general surgical techniques.
Well, perfect, thank you. So let me see here. We have another questions. Marcus Malek, General Hospital. When doing this procedure, I have noticed staining along the skin as well as on the tumor bed. I do at times use electrocautery. So your point about spillage is well taken. Is that staining I'm seeing spillage from my lymphatics, or can you get some staining of the tumor bed from the lymph node itself?
If your dissection is aggressive, I think you can. Let me refer back to this video here. So in this instance, I have the lymph node out of the patient. It's on a back table sitting on a towel. And look at my fingers. So there is spillage. And look at the towel, right? You all can see that?
Yeah.
So there is a little bit of spillage. But you can clearly distinguish between what's spillage and what's lymph node.
Excellent, thank you. And Hector Lagos from Colombia, he said, very interesting. What do you think are the future challenges in ICG used for lymph node dissection?
It would be great if we could penetrate the skin a little bit greater with the infrared technology. And I can only assume that, like an iPhone, that's just going to get better with time. To a point where we could totally obviate the nuclear medicine. Now, having done this for a while, I can pretty much see the direction that the ICG goes until it disappears. And There have been a couple of cases where I have not been able to follow it with my eye, where the skin has been very thick and the lymph nodes have gone very deep. The lymphatics have gone very deep. But as technology improves, it would be wonderful if we could just inject and follow it and not have to do the lymphoscintigram.
Okay, perfect, thank you. And if you consider someone, again, is starting with this technology and you define, I would recommend, you know, they start doing this with the easy ones or the like standard ones. So which ones are the standard ones from someone that is like learning this technology, and which ones say, oh, you know what, in this case, I could use technetium as well?
Well, I would say that unless you know the lymph node basin, you have to be very careful. So what makes a case easy? What makes a case difficult? If you have a patient who is you know, morbidly obese, COPD, smoker, on steroids, you know you're going to have challenges with that case. You're going to have challenges in the operating room, and you're going to have challenges post-operatively. So that would not be my first choice to start. I would, and if I had to pick an ideal first patient, it would be someone with a relatively shallow melanoma, something in the 1.0 to 1.25 range. I would probably pick someone whose BMI was in the 25 or less category, someone who was generally healthy, someone who you're doing a lymph node dissection or a sentinel lymph node on because the Castle test has indicated it's a good idea, or you feel that they meet the criteria. And that would be probably my first case. It's just like any other new technique. You don't start a resident off on a difficult case. You know, you give them the easy one. And treat yourself the same way.
Yeah, have you used this technology in order to follow up the patients that had a lymph dissection in order to evaluate the lymphedemas, for example, or the different stages on how they progress, different techniques?
So when you're a hammer, the whole world looks like a nail to you. Yeah. And in my case, ICG is really my tool of choice for many, many, many applications. And it has been a great tool to identify lymphatics and to help with lymph surgery. So for example, if we're going to treat a patient for lymphedema by doing a lymph node transfer, or we're going to do a lymphovenous bypass, you can identify the lymphatics by injecting ICG in the skin, lower extremity, maybe a 0.1 cc between each toe. If you're doing the upper extremity, you can inject it in and around the fingers, in the web spaces, and you can watch the lymphatics as they begin to, draw that material closer and closer to the proximal lymph node basin. It can be very helpful following a lymphatic anastomosis to make sure that it's closed. My experience with this particular technology is that I use it for everything. I use it for evaluation of mastectomy flaps, for DFs, for evaluation of microsurgical anastomoses, for evaluation of blood flow when I'm planning flaps, for evaluation of lymph node transfers. It's just a wonderful, wonderful technology. It's image-guided surgery. That's what it is. It's like our society. It's image-guided surgery.
Okay, and please, I ask all the audience to make questions. It is the same. You mentioned before that the dose is like pretty standard. At least the dose that you're using, 0.1 or 0.2. So would you change the doses according to the region, or you always use the same dose for like all the regions?
I use the same dose. You're talking about 0.1 or 0.2 cc's. It's a very subtle difference between that and 0.3 cc's, but I wouldn't double it. And the reason I say that is because, like anything else, we kind of did some trial and error here. And when you inject too much, by the time you open up the lymph node basin, everything is glowing. So you don't want to white out your lymph node basin. You want to just put an appropriate amount in. And like anything else, start small. Start with 0.1, 0.2. And if you have to, bring it up a little bit, you certainly have time to do that. It happens very rapidly. We didn't talk about the timing in this. But if you inject and then go wash your hands and then come back, you're ready to go.
Okay. And when you perform this kind of procedure that lives in Cleveland Clinic, do you need any kind of consent to the patient, or you use the same?
No. I mentioned, I mentioned in my original consultation that, we use lasers to help identify certain lymph nodes or, do breast reconstruction. But this is, in my practice, this is standard. I've been doing this for 15, 20 years.
Perfect. And something that you would like to recommend to like the people that are listening or that are here today?
Well, yeah. First, thank you very much, both Dr. Dipp, Dr. Rosenthal, for the opportunity to present. I consider it an honor talking to people who have an interest in this. It's really a wonderful, and congratulations on the society for generating interest in this, because this is the future. There's no question about it. I would encourage people to look at this tool like I look at it, like you're a hammer and the world is a nail, and think about new and exciting applications. I've heard people tagging monoclonal antibodies with this material, with ICG, and then having them go isolate a tumor. And then you can clearly see where the tumor is. So let your minds run free. Think about different applications for this. Get to learn this tool like you would a bovie, and enjoy and pioneer and break new ground.
Thank you very much. I don't have more questions. I would like to thank you very much for giving the talk today. And thank you very much. And thank you, Raul, and thank you, Dr. Newman. And see you in the next webinar.
My pleasure. And I just want to shout out to one of my co-authors on that study, Dr. Kuntz, who helped me to put those numbers together. She's a great young surgeon, and she's going to do well. I thank you again, Dr. Dipp and Dr. Rosenthal, for the opportunity to present.
Thank you. Thank you very much. Bye.
Have a good night.
Bye-bye.